that's it. What do you see?
Yeah, I'm seeing that you have wonderful slides with COVID.
COVID. Shall I make it? I can't see it myself. Okay, do you see my whole screen? Is it?
Yeah. I mean,
Should I-
I'm seeing your presentation. Okay, now this is the first line.
Oh. What do you
now
think?
Good. How many members you have in your societies? I mean, I was astonished because so many participants for...
Wait. I can't hear you very well. What did you say?
How many members do you have during this webinar? I mean, usually in Italy, if we have for the Italian Society of Radiology, we consider a good webinar if we have like 100 members.
100 members. Okay, I don't know actually. We had a good registration so far, but actually I don't know about the attendee, the actual attendee. What is the number going to be? But the team told me that the registration is really full. We reached to 8,000 registrations, so I don't know what.
Oh, it's great.
It's a surprise. It's a surprise for me too.
I mean, you're also for the European society. The European society, it's a huge number to have this kind of to have like 8,000 people that are registered.
Yeah,
you need to consider that usually. I mean, these are.
Should we introduce him now? Okay. It is my pleasure to welcome the speakers, my colleague, the moderator, and all of you, the attendees, to our cardiac imaging webinar from Saudi Heart Association. Our first speaker is Dr. Bisibi Mascogiri. He's from Department of Cardiac Imaging in Monzino in Milan, Italy. Please be my guest, Dr. Bisibi, and go ahead with your presentation.
So first of all, thank you very much for the kind introduction, and thank you very much for the invitation. So, as you know, today we are talking about the COVID-19. The first paper that we saw in literature, it described 3 patients that had this kind of disease. But this article is wonderful because in this article they summarize the pathway of this patient. So they presented 3 adult patients, and the patient went to ICU, hospitalization, and then home isolation. And this is the classic pathway that usually the patient with the COVID-19, they have in clinical practice. So they can go to ICU, hospitalization, or home isolation. If you look at this article, it was published in an high-ranked journal, they showed us how many patients went to intensive care unit and the age range of this patient. If you look at this table, you can see that the majority of patients that went to ICU that were patients with age range between 25 and 49 years old. Is it true? We will discover the answer later. I mean, I will show you what happened in Italy. But let's talk about the effect of COVID on cardiovascular system. You see that there is a direct damage of the virus. You have also hypercoagulability, and at the end, you can have myocarditis, you can have an increased risk of myocardial infarction, heart failure, or arrhythmias. But the hypercoagulability, it can also can lead to pulmonary embolism. And these 2 studies show that patients with COVID-19 can have also pulmonary embolism. And the article that that I show you below, the second article, it's extremely interesting because it showed that the 31 of patients that were in the ICU, they had pulmonary embolism. But let's move to Italy. Let's move back. So what happened in Italy? It was very simple. In the 21st of February, we had 3 cases. On Monday, after just 3 days, the patient rose to 200. After 16 days, I mean the 8th of March, we had already almost 6,000 patients infected. And the 12th of March, we have like 10,000 patients. After that, the government decided to have a strict lockdown in order to avoid the spread of disease. And all the physicians, we had just 5 questions that for us were very important. I mean, the first question was, do we have enough ICU beds? Do we have any drug that can change the prognosis of these patients? Do you have any fast tests that can provide a diagnosis of patient with COVID-19? And what about the cardiac pathologies? I mean, we know that this patient went to ICU in China, but will go to ICU also in Italy. But what about the acute myocardial infarction? I mean, they didn't disappear during the pandemic. And obviously, the last question was about the lockdown and the economic crisis. So I will show you this number. This is the update number. And you can see that the majority of patients had ischemic heart disease. These tables showed and graphs showed the patient that died. The majority of patients had ischemic heart disease, but also hypertension, chronic renal failure. And if you look at the patient that died, the majority were in a range between 80 and 89 years old, with the most common symptoms observed were cough, diarrhea, and obviously dyspnea. So the next question was extremely simple. So if we don't have enough ICU beds, what we can do? And the intensive care specialists were considered also to denying life-saving care to people that were already sick. So it was a very tragic situation. Just to show you what happened, I mean, during the 1st of April, in the early April, we had 4,100 patients that were in the ICU only for COVID, and the total beds for ICU in Italy were like 5,400. So the 3 key points that we decided to, I mean, the first 3 key points that we were focused on the early phase were just 3. I mean, create extra ICU beds, try to find a therapy, and try to find a fast and accurate way to detect the patient with COVID-19. So what about the therapy? Do we have any specific drug? The answer is not. I mean, we don't have any specific drug. We can administer these kind of drugs to patients, but they are not specific for COVID. Do we have any fast test? The answer is no. I mean, we have a RT-PCR, but unfortunately, it's very slow. The time of processing it's extremely slow. Is extremely slow. We have fast imaging tests, but they have low specificity. So if we talk about non-invasive tests, the first that the first technique that is extremely cheap is ultrasound. We can perform ultrasound in this patient, especially in the emergency department, and we can use ultrasound for triage, for diagnostic evaluation, or for sometimes also for prognostic stratification. But I would say the king of the diagnosis in these patients is absolutely CT. Why? Because with CT, we can evaluate the lung that is involved by the disease. We can also evaluate the presence of pulmonary embolism. And we can evaluate CT. We can also evaluate with CT, we can evaluate coronaries. Just to have a rough idea about the findings that we can find in patients with the COVID. So we have a bilateral involvement, usually in the lower lobes, posterior and peripheral, with the pure ground glasses, or ground glasses with the reticular or interlobular septal thickening. This is a patient, this is an example. I mean, you can see that this patient had has an involvement here in the peripheral, and the patient had, this patient had ground glasses areas. Okay, but let's move to another topic. I mean, what we can do with CT, we can also follow the disease. We can do a follow-up of the disease. So if we have a patient that is worsening the condition, the clinical condition, we can evaluate if there is any changes, any very quick changes in the lung. So if you look at this article shows you that usually the typical pattern is with ground glasses, but over the time there are also an overlap. I mean, there are also consolidation in the parenchyma. And here I can show you a case of a patient. He came in our hospital with a fever, 38 degrees, dyspnea, oxygen saturation was 95, no other pathologies. CT was positive for COVID. As you can see, there are several ground glasses areas, peripheral, especially in the lower lobes. And after 2 days, the patient, the oxygen saturation went from 95 to 90%. So we decided to acquire again the CT, and you can see that this patient the of ground glass increased a lot, and he had a very fast progression of disease. The other thing that you can, the other information that CT can provide is the presence of other infection. And I will show you this case. This case is a patient of 50 years. This patient had it was positive for COVID. It was a Tom. He had home isolation. He was in home isolation. He had 7 days of fever. Then for 4 days he was normal, and after 4 days he had the other 3 days of fever. The oxygen saturation was 89%. But if you look at the CT, there were some findings that were not typical for COVID. For example, he had lymphadenopathy that is very uncommon in COVID. And he has also consolidation on the lower lobe. And at the end, this patient, the final diagnosis was COVID-19 plus pneumococcal pneumonia. So sometimes you need to remember that CT lung is indicated in case of discrepancy between clinic and radiological findings. And it can be very useful in patients with very fast worsening of clinical condition. But the question is, can you use the CT also for, for screening? I will say no. It's not possible to use as a test of screening, because you look at the positive. It's in Taiwan, with a prevalence of 1%, the positive predictive value was 1.5. And it was increasing in China, where the prevalence was 9. The positive predictive value was 48%. Look here. Here, this is the data of the United Kingdom, of UK. In April 6, the prevalence was 23%. Look at the positive predictive value of chest CT compared to the RT-PCR. So now the best test to diagnose COVID-19. I mean, okay, you can perform CT, but the gold standard is still RT-PCR. And I will show you one case. In this case, for example, we had a discrepancy. The patient had a fever. The chest X-ray was negative. We performed the CT, and the CT was negative too. I will not show. I mean, I have some issue with the video. But if you look at the CT was negative. So in this case, we had a patient that was positive for COVID with RT-PCR, but the CT lung was negative. Now I'm showing you this article. It was recently published, probably today, and this is extremely interesting because beyond the diagnosis, maybe the CT can be helpful for prognosis. In this patient, in this article, for example, they create a combined model with clinical information and imaging information, just to see if there is any correlation between the involvement of the lung, the percentage of lung involvement, and the ICU. I mean, the need of ICU care. And what they saw that if you have a lung involvement that is over, if the lung involvement is extremely high, and you have for example, cardiac disease, the percentage, a lot of people went to ICU. So the model with the clinical parameters and CT can provide information regarding the possibility to need intensive care unit care. Now I will show you another case, very interesting. This patient had she had COVID, and the CT was positive for COVID, and also the RT-PCR was positive for COVID. If you look at this patient, beyond involvement of the lung, there is also pulmonary embolism. So sometimes, especially if you have increased edema, and if you remember, there is also correlation between the hypercoagulability and COVID. Sometimes you need to perform also CT pulmonary angiography to assess if there is any presence of pulmonary embolism. And yet, it's coming from some article that probably could be helpful to administer heparin in this patient. Also, like, I mean, before at the diagnosis, they started, I mean, in Italy, they started to administer heparin to this patient. Now I will show you another case. This patient, 77 years old male patient, he had cough, dyspnea, increased troponin. CT lung was positive for COVID and also RT-PCR. So considering that the troponin was not very high, we decided to perform a cardiac CT. And if you look here, you can see that there is a stenosis, a severe stenosis on LAD that was confirmed with coronary angiography. If you look at the guidelines of the Society of Cardiovascular Computed Tomography, they also suggest to perform CT in this patient, especially because you need to consider that if a patient where you are not sure that the patient has coronary artery disease is hospitalized, you are wasting money, and you are occupying a bed that potentially could be occupied by a patient with COVID. So sometimes you need to consider that the negative predictive value of CT angiography for coronary artery disease can be extremely important in the management of the patient with COVID-19. So again, if you look at the key points of this presentation, I suggest you to perform CT lung only if necessary. So if you have a mismatch between clinical features, chest X-ray, or you have a worsening of a clinical condition, and don't be afraid to administer iodine contrast agent during CT if necessary. So if you need to evaluate pulmonary embolism, you can do that. It's safe. If the patient has not any renal injury, you can do that. Don't worry, but you need to consider that this patient can have an increased risk of pulmonary embolism and also to have a acute coronary artery disease. The other suggestion that I can tell you is to have a clean and dirty pathway. I mean, you don't have to mix patients, healthy patients with COVID, because in this way you can increase the contagiousness of the pathologies. And people that are coming from emergency department should be considered dirty until the results of RT-PCR or imaging, and try to minimize the diagnostic examination, because obviously all the examination, they expose people, the healthcare personnel, to COVID. So at the end, this is the last slide, the aim of the hospital is to reduce, obviously, the COVID exposure of healthcare professionals, and also to have an accurate distinction between patient negative and positive for COVID. Obviously, this is useful for prognosis, therapy, and contagiousness. And you also need to have a quick diagnosis and treatment for COVID, for patients with COVID, because in this way you can decrease the ICU patients and also the deaths. So thank you very much for the kind attention.
Thank you, Dr. Ghossebi. Dr. Yasmin, can you
Yes.
Go ahead, please, and introduce the second speaker.
Would you like to take the questions for Dr. Ghossebi, or we will leave the questions on?
I'm open for both. So what do you think?
What do you think, Dr. Ghossebi? You want to answer some questions? We have one question here, if you want.
Yeah, I mean,
a question in between for Dr. Anna to get ready. We have Asil Badkhon. She asked, when do the changes of lung start in COVID-19, and is it related to this disease progression? The time interval for the disease progression and lung changes.
So, I mean, there is no a real strict correlation between the lung changes and the onset of disease, because there are some patients that, for example, as they didn't show any kind of lung disease, but they were positive with the RT-PCR. So they had cough, they have fever, but at the end the lung was negative. And there is not any correlation in terms of times. The article that I showed you show that there is like a kind of trend, but at the end, in clinical practice, there are some people that had a worse clinical condition also after 2 days. So there is still not a real strict correlation.
Mm-hmm. Actually, there's another question from Muhammad Kashif. He asked you, do CT has only assistive role for disease prognosis, or it can also help for reconsidering COVID if initially RT-PCR comes negative? So he wants to use the CT as a diagnostic if the RT-PCR. I think you said you concluded that in your lecture, but you could answer him if you want, Dr. Ghossebi.
Yeah, thank you very much for the question, because this is a really important question. So my suggestion is to don't use the CT as a test of screening, because the real problem is that the specificity of this test of CT is extremely low. So the risk is that you acquire a lot of CT, but at the end you cannot be sure if you have COVID or not. So I think that at the end, probably the blood test would be the future. But until now, I don't suggest to use CT as a test of screening, because you need to consider also another scenario, that you perform CT, probably you have a false negative of RT-PCR, but you are exposing personal healthcare to virus, because the personal healthcare, they are doing CT, and I mean, it's it's not so easy to justify in this case that you perform a test where the specificity is extremely low.
Actually, taking into account that COVID-19 virus has a different viral shedding. So even if you did the RT-PCR, when the viral shedding is not really there, then you have a negative test, not because the test is not sensitive. Actually, the specificity and sensitivity is 100% for RT-PCR.
Exactly.
But actually, the location also of the sample taken, if the virus attack in the upper respiratory tract, that's well done. And if it's in the lower respiratory tract, then maybe the sample is not enough to show the viral activity. So the CT can help, yes, as you said, but actually the RT-PCR, it can come negative, maybe the timing of the sample taken and the site of the sample taken. So if it's upper respiratory and lower respiratory, and also the interval, so you might catch the virus at the start if it's there, but if you wait for a repeat test of 72 hours, I know that they do in Italy such a way, you might get the RT-PCR negative. So the sensitivity is 100% when it is positive, but when if it's negative, I think you have to repeat the sample from different siting and give it a different timing interval in respect to the COVID-19 virus activity. We have 5 minutes past after you. Sorry.
If I can also add you a comment, you need also to consider that obviously the test can be detected. I mean, you perform the test only in patients that are the majority, they have symptoms.
Yes. Okay. Yes. This is according to the CDC score. So you have to follow the score if there is symptoms of exposure.
Exactly. But the real thing is that, for example, in Italy now we have like over 100 of people that we know. It should be like over 100,000 people that we know that are infected. But at the end, when we will perform blood tests, I think that probably there are several studies that they are telling us that probably we have like more than 10 times the people infected. So it will be, I mean, I'm sure that when we will perform blood tests, we will have very interesting results.
Exactly. There is another question from Salim Habshi. If the patient has highly suspected COVID-19 with negative PCR for COVID-19 2 times, but the CT lung is highly suspicious, how can you treat this patient? Is it considered as a case of COVID-19 or no?
Yeah, I mean, in this case, if you have fever and you have pathological findings on CT, you still, if it's not COVID, maybe it's another disease.
Another pneumonia.
Yeah, another pneumonia.
Yes, it's not COVID-19 virus, but it is another type of pneumonia.
Exactly. So, and what you can do with this patient would be the same that you will do with the COVID-19. So you say, okay,
isolation.
Yeah, exactly. Isolation. Stay at home.
Stay at home. Exactly. So another question here is: fever is present in all cases for COVID-19. Do you see patient always with fever?
No.
This is Ahmed Abdul Karim.
No, unfortunately not. And this is I'm saying unfortunately because the real problem is that when you don't have fever, you have the patients with patient with virus, but you cannot recognize him. So it's more dangerous because the patient has not symptoms, no fever, nor dyspnea, nor, for example, cough, and but at the same time, the patient can spread the virus.
Okay. So yeah, as we said that despite we need to do the score of the CDC, we know that the sensitivity of the score is not that much high, and fever one of those scores. So
yeah,
it's not the
exactly.
case, unfortunately. And we know that the virus also has a vascular and neurological pathway that patient might present with headache and GI symptoms, which is not included in the CDC score.
Yeah, exactly.
So we had also Mohammed Jarullah ask, what is the CT sensitivity in pediatric patient with COVID-19?
So until now, there are not so many articles, but it's still low because you need to consider that you have an overlap of other disease. So unfortunately, a CT, I mean, to be honest, I'm not a fan about CT for COVID-19, but I think that we will have a role of CT more for prognosis instead of diagnosis. If we need to have a look on diagnostic aspect of CT, I can tell you that I can tell you that for me it's extremely important, especially for evaluation of pulmonary embolism and if there is a worsening of clinical condition.
Well, we have to know there are other schools considered cardiac CT if the patient is suspicious positive as a high-risk COVID. So if you do CT chest and it is suspicious, then this is a high-risk COVID. This is what other society also are recommending, despite your school actually is not really going on with this recommendation, I believe. So I have one patient, one question, Zawi. There is a heart failure, and how can we differentiate between COVID and lung edema?
Yeah, this is
Heart failure. Yeah, this is always the debate.
You cannot make any differentiation, unfortunately.
But radiologists, they do it sometimes on the report.
Yeah, but it's I mean, you can do it, but it's extremely difficult, and this is the reason why the specificity is extremely low. So sometimes you need to have a look more on clinical information instead of.
So you are a radiologist, and you're saying that we cannot diagnose heart failure.
I mean, you can do that, but it's extremely difficult. And you need to be honest. You can say, okay, for me, it's more COVID than heart failure. But you need to be honest. I mean, there are some cases where you have like also people with heart failure that you can say, okay, this is 100% COVID. For me, it's 100% COVID. But sometimes the CT findings, I would say that in the majority of cases, you have an overlap.
Absolutely. I think I reiterate what Dr. Gosebi is mentioning. There is new data from Washington, DC, for patients from the ICU from COVID. They mention clearly, reiterate what you are saying, that heart failure can present as a feature in CT around 10 to 12% of all COVID patients. So it's really difficult to differentiate radiologically alone without taking the clinical context altogether.
Yeah, totally agree. I think that the real difference will be the blood test, because with blood test you can have just with blood sample you can have a very quick test, and then with CT you can assess the prognosis, or you can you can say, okay, this patient has like 73% of lung involved by the disease, and there is an high risk to put this patient in the ICU, and or you can perform CT and say, okay, now we need to administer contrast to evaluate pulmonary embolism. But for diagnosis, I'm not so sure. Also, the American College of Radiology is not so, it doesn't agree to have a CT for screening in patients with COVID.
Okay. So it's 8:30, and we can stop at taking the questions, and maybe later on we can answer though. I will go with the next talk with Dr. Anna. Dr. Anna is a consultant cardiologist and specializes in cardiac imaging, cardiac CT, CMR, and echocardiography. She's practicing at St. George's Hospital, NHS, London, UK, and she's going to present her talk about cardiovascular imaging in COVID-19. Anna, go ahead. Thank you. Unmute yourself, Anna. We can't hear you. Yes?
Can you hear me now?
Yeah, perfectly.
Okay, lovely. Thank you very much. So, listen, thank you very much for your invitation. I've been delighted to sort of receive it. And I do work as an imaging cardiology consultant, and I do cover echo and cardiac MR. And I wanted to start with this sort of a horrific map, which is the worldwide map of patients who were infected with COVID. And we are all aware of the horrific statistics of the current number of COVID patients and also mortality in this group. And when I looked at it from this morning, sort of the Italy had more than 180,000 cases. We in United Kingdom had more than 130, and you guys in Saudi Arabia had to sort of more than 11,000. It sort of takes us to sort of a 2.5 million of total cases worldwide, with also a significant mortality, as you can see. And I'm just moving to the United Kingdom. I'm based in St. George's Hospital. We normally have a 9,000 staff, and we served 3.5 million population across southwest London and local areas as well. And as you can see on the left side, this was just taken from one of the sort of newspapers, where the way how many numbers of the current official UK cases as of yesterday we have, and this is the 22,000. It's purely across the London hospitals, and this actually definitely sort of influenced the change which we've been going through in all our hospitals, where we could clearly see at St. George's that, similarly probably in your places, that lots of wards which were normally serving patients for general medicine now suddenly transformed to be a COVID wards, and also we suddenly started exponentially increasing the number of intensive care beds, and we took every possible area where we were able to put a ventilator, and this is all being provided by our excellent intensive care team. So moving on, the available data from China, from Italy, and as well as a recent experience in the United Kingdom and United States indicate that COVID can be mild condition in a certain group, most of actually of affected patients, but in others can be actually severe and deadly. This is this invisible enemy which we all face, and that's why we have to protect each other from it. And this is where I wanted to move on to the work which we do in our echo department and in our cardiovascular imaging sector, the way how we approach those patients. So we approach the situation in sort of a 3 steps way. The step 1 is assessment of infection status of COVID. Step 2 is reviewing actually indications of echo, and the step 3 is delivering of the appropriate imaging, and also what's very important is staff safety. Just stopping here is we cancelled most of our elective work. The elective work in the echo department and cardiac MR department has been focused on only urgent scans where we know that this will change patients' management. Otherwise, most of our work currently are the inpatients. And moving to the step 1, we assess infection status of COVID patients. And with regards to the inpatients, we have a luxury of having a lot of serology in those patients, which was able to sort of guide us towards whether it is positive or negative COVID. otherwise, and also we can ask questions through the clinicians or directly patients with regards to these symptoms. It is slightly different with outpatients, because some of them, particularly some patients who are waiting for high risk procedures, who need to have them urgently and they need an echo assessment. Also oncology patients who are waiting for the treatment, where this sort of monitoring with LV function is very important. Those patients, we do ask them questions about a fever, cough. We obviously ask them about contacts with a person with these symptoms, and also a person with contact with a person with confirmed COVID. And we actually, on the right side, I sort of put our public health guidance with regards to a personal protection equipment, which we have actually locally in our hospital. From echo point of view, we slightly modified, and the way that all patients with a confirmed or suspected actually COVID, we are using a full PPE equipment when we scan those patients, because obviously most of our physiologists, our doctors who are scanning, we are actually right-handed, so we are in a very close proximity to those patients, and then we use sort of a goggles, we use visor, we use gloves and apron. And with the COVID negative patients who are completely well, we still use protection in a form of a surgical mask, in the form of a plastic apron and gloves. So we still sort of protect ourselves. Moving to the second step, we then, after assessing COVID status, we then review indications for echo. Is there actually need for an echo? Is there any change in management? And this actually applies mainly to the inpatients and echo and COVID patients. The clinicians, the intensivists often requested when they feel that there is a clinical deterioration. They are interested obviously in assessment of the function of the ventricles, the presence of pericardial effusion. Saying that, we've just been introduced a very focused echo. There is our excellent intensive care team, which is screening very focused, very limited echo in all patients which are on intensive care with COVID. And those ones where there are some suspicious findings, then they are being requested for more sort of the larger proper study then. Otherwise, we are a big tertiary center who provides the service for acute coronary syndrome patients, where by doing an echo, we can guide the management with regards to intervention or medical therapy. Those patients who come with us with the STEMIs or NSTEMIs and they become hemodynamically unstable, also pulmonary edema for the valve assessment, tamponade and pericardial effusion, which I'm sure you do all in your centers. Also, another area is patients suspected of heart failure. And this actually, this applies to both inpatients, outpatients. We've got a large heart failure team who's very sort of very good with contact with finding the patients with heart failure, and they realize that a lot of patients are actually scared of coming to hospital, and loads of new suspected heart failure patients with high BNP and shortness of breath, they are scared of coming for the scan. So the heart failure team sort of is in a sort of, we created our sort of a clean areas where those patients from community, they can present to our local points in community where this echocardiogram could be performed for them without them entering the hospital. And also other reasons for chest pain, acute PEs and aortic dissection, and particularly the PE, which I'm just going to be talking about a bit later on, which actually sort of confirms this, what Giuseppe was saying about the increased prothrombotic episode in those patients with regards to the frequency. So, and then the last step is delivery of an appropriate imaging, and all COVID positive patients, we all scan them on the wards. They are all done by portable machine. which is being cleaned after every echo study. We also created a little area where our team is changing to the appropriate equipment, and then they can obviously change then later on into the new scrubs, the new clothes. Talking about then the primary PCI service, every patient who is being brought by an ambulance is being assessed by our clinician, by our resident, cardiology residents, and during that time they do perform echo for those patients. We use the little handheld echo, which you can see in the right lower corner, which I'm sure you also use in your centers. We find them very useful because this can help guiding decision and adds on top of information which is in ECG and clinical history. And we get all the key information we obtain during the scan, and we really do a minimal scan at a time. It usually takes sort of a roughly 20 pictures, and this is all for the assessment of function, pericardial effusion and valves. And then moving, so this is about transthoracic, the TOE. The TOE is as we all know, it's aerosol generating procedure. Therefore, we need to use the full personal protective equipment. And this is actually TOE, which I've done last week. You can see this is, I'm here on the right side with my colleague. You can see I've got the sort of the visor. I've got a FFP3 mask. I'm in a scrub under that, and then I've got this sort of a very light gown. I'm double gloved, and I've got sort of a high wellies. And this is actually also the outfit which our interventional cardiologists are using. We are actually using it in the cath lab area. And again, this is all, we go through sort of a room 1 where we put everything on, room 2 where we change the shoes, and then room 3 where we enter it. And this is actually our interventional colleagues. On top of this, what I've got also have obviously the lead apron and then the sterile gown on it, so they really feel hot. This is always what they say. So with regards to coming back to transesophageal echo, every TOE is being triaged by clinical cardiologists with regards to the COVID status of the patient. Then we review a transthoracic echo, and we actually decide whether this is actually clinically urgent scan and whether it will change the management. And actually I deal with a lot of endocarditis patients. I'm part of a big endocarditis team at St. George's, which we set up with our cardiothoracic surgeons and microbiologists. So you can imagine that I'm sure you come across patients who do come with fever and they have endocarditis. So in the current era of COVID, it is very difficult where patients do come with fever, they do have valvular heart disease, and sometimes it's maybe the first sort of a COVID swab may come negative, but they still continue spiking. So obviously we have to still keep investigating them. And then, as you see, we have a limited staff number. So really, literally, myself and my colleague, we were the only people inside the room performing the scan, and we had nurses just outside the lab, which were monitoring the patient observations. And after that, we finish and we do the cleaning of everything, and we use mainly the chlorine-based equipment to swipes and to sort of clean everything. So at that point, I just before I move on, I just wanted to sort of say very few words. I also do cardiac MR in our patients, and we do not have a sort of a dirty and a clean scanner. We only have a clean scanner, so we only scan the patients with COVID negative, and this applies to patients with sort of a myocarditis who had negative COVID screen, and we obviously we are not doing any elective cases. I mean, rather the amount of elective cases minimized significantly to only very urgent one where the further management will be warranted depending on the decision. So I just want to now move on to sort of a little bit more clinical part, then so just finishing the protection part. And then, you know, you probably also this American College of Cardiology slide where the case fatality rates for comorbid patients is higher in a average population when they have a cardiovascular disease, and it sort of applies to 10.5%. However, if you add on this what Giuseppe was saying before, that loads of the patients, and you do see them, they have diabetes, they have hypertension, then this percentage just multiplies further. And there was a recent study published by a group from Wuhan, which was published in JAMA Cardiology, which looked at those cardiovascular implications of fatal outcomes of patients with coronavirus. And they looked at 187 patients with mean age of 58 years, and out of this group, 77% was discharged and 23% died. And when they looked actually the mortality of those patients, as you would suspect, is that the highest mortality was patients with cardiovascular disease and with elevated troponin. So they really noted that a lot of patients who prognostically were not doing well, they had a high level of troponin, and the mortality was up to almost 70%. With regards to patients without cardiovascular disease with the normal troponin, their mortality was only 7.6%. And then another slide from this same group, they looked exactly at the sort of the level of troponin T and NT-proBNP. And again, when you look here, these are the fatal patients, or patients who died, and they did have a high and raising troponin levels as well as NT-proBNP. So this is sort of a very bad prognostic marker when you start having those patients with the raising troponins. And then the cardiac involvement, I don't want to repeat what Giuseppe already said. There are multiple different etiologies: myocarditis, stress-induced cardiomyopathy. There is obviously hypothesis that there is a strong microvascular thrombosis in these patients, and you know that they are very prothrombotic. They do develop also the either large PEs or multiple PEs, and we do see it on our right in the form of right heart failure in these patients, and I'll show you a case like this in a minute. So just moving to, because I'm aware of the time, just moving to the clinical cases, I've got a lady who's 63. She really came at the time very early when we started having the first cases of COVID. So obviously she came typically with 5-day history of a cough and shortness of breath. She had high D-dimer. She came through A&E, had a routine blood check. As she was short of breath, she had D-dimer check. It came high, and then hence the CETPA was requested. There was no PE, but there was multifocal ground glass opacity, which was reported on CT. So obviously the first thing was, this patient, does she have a COVID? And this is how the samples were sent. Her background included a pacemaker implantation for 2-to-1 block. So she was known to cardiology. And this is the reason why we know that she had a normal coronary angiogram 2 years ago and normal echocardiogram only in November 2019. She had a background of hypertension, diabetes, and she was obese, which you can appreciate also on the scan itself. And then when you look at so she did test positive. And then when I show you this is her echocardiogram, I hope you can all see that she does have a very severe global left ventricular systolic impairment. And she was actually stable for first 5 days. And then after that, her oxygen demand started increasing. She became tachycardic, hypertensive. And this is something which we see often, like at the 10 days of since initial symptoms. And it was well described about the whole cytokine rush. And then she was transferred immediately to ITU for intubation, mechanical ventilation. And this is somebody who had a normal coronary angiogram only a few months ago, normal echocardiogram only a few months ago. Unfortunately, over the time, she had a high requirement for vasoactive support. She was referred for ECMO, however, felt not to be a candidate, and further developed a multi-organ failure, and unfortunately died 13 days after her first symptoms and 8 days since the presentation to hospital. So I think it's probably one of those typical cases which you came across, and which actually we came across for one of the first cases in our institution. And the second case is somebody, this is my sort of a personal experience with this patient. So I do cover clinical cardiology all the time. We've been rotating through the on-calls in cardiology, and this was one of the patients who came 2 weeks ago. She's a 78-year-old female who came with a sudden onset of shortness of breath. She was brought by an ambulance as a query STEMI call. Her husband passed away a week ago because of a COVID, and he actually stayed for 2 weeks in hospital where she was hospitalized, so she hasn't seen him for 3 weeks. She had a background of diabetes and hypertension, and actually this is her ECG. I'm sure you can appreciate sort of a pretty widespread ST elevation in sort of in inferior lateral and sort of anterior lateral leads. And she actually, on arrival, she had pain. She was pain-free. She was in pulmonary edema, and she responded really well to furosemide. She was then discussed with one of our interventional cardiologists. She had an echocardiogram performed by our resident in cardiology, and you can see, I'm sure you can all appreciate that she does have this sort of a mid to apical echinacea of her segments, and because she had this sort of features with quite a hyperdynamic basal segment, so there was clearly a very strong element of a stress. She did have a widespread ST elevation with those mid to apical segments, echinacea. And so we were wondering, considering she was pain-free, she wasn't taken to the lab, and then we thought that we are dealing with actually a Takotsubo patient, which means that we decided to then go for a CT chest and to do the COVID status, particularly because of her contact with her husband, even if she hasn't had any symptoms. And this way, I just wanted to emphasize the importance of cardiovascular imaging, and actually multimodality imaging, because sort of echo indicated strong suspicious of stress-induced cardiomyopathy. And then CT chest with CT angio, actually CT chest part confirmed this peripheral consolidation suggestive of a COVID, and indeed the COVID swab came positive, and then interestingly, as somebody who was diabetic and hypertensive, she had a CT coronary calcium score of 20 with only minor coronary artery plaque. So she's done really well, and she's actually currently being sort of recovering. She's been very well. Her repeated echocardiogram only 2 weeks later showed almost complete normalization of her LV function, and we are getting her ready to go home. So even her recovery has been quite quick. So she's still an inpatient. And at that point, I just wanted to very briefly sort of change before I show you the next case, is a mention about our protocol for a primary PCI pathway, which we have at St. George's. As I said, we see patients initially with regards to the, I'm sorry. We see patients initially for the for assessment of those patients who are coming with the primary PCI calls. We see them, assess them. If we feel that they are cardiac, they are being taken to the lab. And this is the point where we decide to put them into 3 categories with regards to COVID. So they are confirmed or high probability cases. These are patients with fever, cough, and or recent contact with COVID. There is a main moderate probability, because patients often, as you came across, they're coming with respiratory distress. They may be in pulmonary edema with no fever, and this can be related either to the heart or due to the COVID. And rightly, we did put these 2 categories together, and if this is they're being put into this orange or red category, then we are doing this those patients in a cath lab for in the so-called a COVID lab. So this is the lab which you show on the background of my TOE picture, where there is special rooms for a changing, and then this team is sort of ready to be in a for PPE. We also, in our pathway, we created a thrombolysis possibility because we were worried. I mean, this was created obviously by my colleagues, interventionists, because there was always a risk that what will happen if those patients will start coming and there will be only one lab available. So we had to put thrombolysis into possibilities, and we had a plan for it. So we had to reinstate all the protocols which were ready. But as far as I'm aware, we haven't had to use it. And something which you probably also noted, because we spoke yesterday with Dr. Khaled and Dr. Yasmin, that the amount of the primary calls which we are getting these days is significantly reduced, and patients at some point are not coming to us from community. The number of the patients with MI is significantly reduced, which worries us. And then this case, just wanted to show you, it's the 67-year-old patient who presented with anterior STEMI. She underwent a PCI to LAD, and you can see that she does have sort of moderately severely actually impaired LV function with sort of apical sort of akinesia here, and she indeed had occluded LAD. But what's actually the reason why I want to show you this patient is that this was her ECG, her chest X-ray, and she came. So she actually had no symptoms of COVID whatsoever. She wasn't in contact with anyone, and she had no fever, no cough, nothing. And this was on admission at the time when she had her PCI. So this was really chest X-ray, which really worried the team. And then they decided to put the patient into the side room and then monitor her. She's been really well. And then 2 days later, her repeated chest X-ray looked like that. And obviously the saturation started going up. And obviously at that point, she did have a COVID status checked, and her COVID came negative. And this actually made me really realize the sort of when you were talking about one of the last questions to Dr. Giuseppe was about the patient similar to that. This is exactly the case which we had when we had patients with absolutely no symptoms with this type of a chest X-ray with a COVID negative status. So we decided to monitor this patient, and then we went for the CT at the time of the second chest X-ray, and this is exactly what we saw. These are the florid airspace changes throughout both lungs, and there's a lot of ground glass opacity and also interstitial thickening. So obviously we have an excellent COVID team from a respiratory intensive care team who's doing a lot of ward runs and seeing those patients on a daily basis. So our diagnosis was actually that this has to be a presumed COVID, and we have to continue monitoring. So this patient is really literally now an inpatient, and she did have a 2 negative swab. So we do treat her as a possible COVID patient. As Dr. Yasmin and Dr. Giuseppe said, it's like you'd have to assume this is some form of a severe pneumonia. She, regardless of that, so she's now additionally on antibiotics, and we keep monitoring her, and we are sort of watching her, particularly with regards to her background of already known significant LV impairment and the presence of mitral regurgitation. And really very briefly, the case which I sort of received from one of our intensive critical care consultants, it was a lady who, it was actually a gentleman who was diagnosed with a saddle embolus, and they managed to pick it up with regards to the sort of the pulmonary artery, when you can see that there is a clot here. On the left side, the echo, you've got sort of a D-shape, a ventricle with a high P pressure of a 65 millimeters of mercury. This patient did really well because he was thrombolyzed and is currently sort of recovering on the intensive care unit. So I'm sorry, I took probably more time, and I just wanted to say that I think we are all learning about these patients. We are learning by experience from China, from Italy, throughout the world. We are gaining our own experience. But I think the bottom line is we have this invisible enemy which we have to fight all together. And we really simply have to stay united and work closely. So that's why I wanted to say big thank you for this sort of amazing opportunity to speak to you today. Thank you.
Thank you.
Thank you, Anna, for the wonderful presentation. And actually, I would love you not to stop both of you, but we have a time limit actually. What do you think, Dr. Khalid? You have a comment? I have a lot of things to ask you, Anna, about. So the patient with the PCI, then it tend to be positive with the STEMI? Did I catch you right?
No, the patient with the STEMI is we treat the patient as a COVID patient, which means the patient is in isolation, but we had 2 throat swabs which were negative. We had cases where the initial throat swab the PCR was negative, but then when the sample was taken, when they were later on intubated, for example, and it was taken by the intensivist.
The bronchoscopy, from the lower chest, yes.
Absolutely, then it came positive. But however, this patient currently doesn't need intubation. We have 2 negative samples of PCR, and we sort of assume this patient does have COVID, even though we don't have it sort of formally
reported. So that's really emphasized on the site of sampling when you take it. If it's upper respiratory nasopharyngeal swab, then it might not, the virus not affecting the upper way, so it might be very, very lower in the airway system. Then that's time you get the right sample with the right positivity. That's a very, very good example of the sampling, the site of sampling, and the results of COVID.
And another thing, Yasmin, as you mentioned, and Dr. Anna mentioned, certainly the site of sampling is very important. Sometimes I notice also the ICU staff are hesitant to take the sampling from the bronchoalveolar lavage. Like today, I have a patient where we suspected COVID, and I asked him to take, we have already nasopharyngeal swabs, and both of the 2 samples on 2 occasions were negative. So I asked for BAL. Now the ICU team, it's easier for them to do the usual protective personal equipment rather than having the full protocol for the aerosol or airborne protocol. So they were hesitant for that. So you have to push them for the BAL sampling.
Yes, absolutely. But we realized that there were cases, I know it also from our critical care doctors who are doing an absolutely amazing job, that actually the clinical deterioration in loads of these patients, which required them to be intubated, actually showed that in a certain percentage the first swab was negative, but as soon as they took it really lower down, in intubated patients, the PCR came back positive. So as Dr. Yasmin said, it's all exactly like depending on where we sample it, the way how we sample, and that's true.
Another point I want to share with you, if all of you allow me, how do you differentiate? Sometimes you have the Takotsubo or the reverse Takotsubo, and it comes with ST elevation, and and it's high risk patients. Would you thrombolize him, and if it didn't come down, you have to take him for the cath lab, or you want to take him for the CT, see his coronaries? How do you make that judgment?
So actually, this, in a normal circumstances, if this wasn't a COVID situation, this patient would immediately go to go to the lab, and we would do, and often we would find out that, for example, coronary arteries are normal. In this particular case was because there was high probability of this patient, but also on a clinical ground, she was a bit in pulmonary edema, she had no chest pain, and she started improving from that. We decided to sort of wait and see what happens, and the echocardiogram was strongly guiding us towards that this is both history as well as the fact that this widespread ST elevation, often if this was sort of LAD, we would expect also to see more reciprocal changes, which we couldn't see in this patient. So this was pointing towards the Takotsubo cardiomyopathy. But at the same time, I know that we can have a really large LAD, which is wrapping around the apex, which can give this impression. So it is absolutely right. But we decided to sort of base on the combination of this sort of the history, this widespread ST elevation, and the echo, we decided to sort of see how the patient feels. And then she's been stable. And we, because of the COVID status, we went for the CA and CT chest at the same time, which confirmed both. And actually, patients done really, really well. But I completely agree. What happened if, for example, because this woman, she was diabetic and hypertensive, so her risk for the presence of coronary artery disease would be high even in view of those risk factors. Then, obviously, if the CT, a coronary angiogram, would have showed sort of widespread sort of a diffuse calcium, you would have done the angiography, and in a lot of patients we end up doing it anyway. So I think this shows that there is element of flexibility between clinical decision and each individual patient. So this is what we did this time, and it sort of worked. But often with those patients, we do those CATs, and until we see that the angiogram is normal or just with minor, we just don't assume that this is Takotsubo.
Yes. Dr. Yasmin, you can go ahead if you have
the question. Yeah, we have questions here for you guys. You feel free to answer. What is the cause of lung disease in COVID patient? Is it ARDS or microthrombi causing a lung injury? Dr. Gasiba, I think you explained that they have abnormal coagulation and pulmonarism plays a part. What do you think?
Yeah, I think that sometimes the case is mixed. So you have both. And I mean, if you think about the small thrombus, I mean, they were found on the autopsy. But at the beginning, we just found pulmonary embolism. In our hospital, we saw that there was an increase of MINOCA, but we didn't figure it out that the real problem probably was the coagulation. So now it's more easy because in Italy, we are treating this patient also with heparin. And if you look at our curve, the intensive care units now are more free, probably because we are treating better this kind of patients.
So yeah, so high possibility that patient with COVID pneumonia, they have pulmonary embolism. So you treat them prophylactically with heparin, is that what you mean?
Yeah.
Okay. So a question from Mustafa: if the patient has RT-PCR negative and CT lung is negative, but angio showing pulmonary embolism, multiple sites, can we consider it COVID positive 19? If he has a pulmonary embolism only?
No. I mean, we need also to consider the clinical situation of the patient. And I mean.
Okay, that's no. Then we have. Okay, so I think I might ask a question. What would you suggest for patient who have 2 PCRs negative, but have typical COVID feature on CT? I think we answered the question.
Yeah. I mean, just home isolation.
Isolation, yes.
Yeah.
And then I think you repeat the sample from different side,
exactly.
lowers
exactly.
bronchoalveolar lavage, and consider him as a suspected COVID, and then maybe the time interval between the PCRs, but he has already 2 PCRs.
Yeah.
Okay, another question. Okay, the spread of virus started from first days or after a few days after entering the body. This is Ayman, I think. He is asking about the spread of the virus. What is the time interval? I think the COVID-19 so far has an incubation period of around from 14 days, sometimes average of 5 days. And then there is, after the symptoms, there are viral shedding, which is variable also. So exact time is not there. The incubation period has to be taken into account, and also the viral shedding, sorry. Okay, then why symptoms of the disease appear late? Ilaf, I think we answered the question. Ilaf, that is because of the incubation period and the site of the sampling and the timing of the viral shedding and the time of the sample taking. And how can we convince public for strict isolation? How we can convince the public for strict isolation?
Well, they are doing great job, at least in Saudi Arabia and everywhere in the world. But you cannot do more than the public has already emergencies, humanitarian issues. You cannot do them 100% all the time. But the success rate we have up to 70 to 80% of restrict public activities make a big difference in the counts we have, at least in Saudi Arabia. And we are proud of it. and we are doing great job. Now, every place in the world, they are doing great job in public activity restriction, and certainly the problem is not the problem for the public. The problem is we have a disease, we don't have vaccination, and we don't have treatment. The public are helping us, but still, as a scientist, we need to go forward and help them with treatments and vaccination in future.
Hopefully, yes, vaccination.
Yeah, totally
maybe
agree.
Yeah, I think Oxford University, Anna, they are doing the vaccination in human trial.
A lot of centers is working on it, and obviously we're all waiting and waiting, but I don't think so anything is gonna, based on this, what I'm hearing, what you are hearing the same way, nothing is gonna come with the next sort of a year, or but so yeah, we are all looking very much forward to the positive results, but so far we've been in a lockdown for the last 4 weeks, and we know that in UK nothing is going to be lifted for another 2-3 weeks at least, and then we will see. So you guys in Saudi Arabia are doing really well when I looked at the numbers, and it looks like that the public, one of your doctors is asking what to do to make people listen. It's whatever you're doing, is you're doing the right stuff, and because people do listen. In the UK, the media is trying to show a lot of cases of patients who were really very unwell, to actually make people realize the sort of extent and severity of the disease. So we are currently on the plateau of the cases, and we plateaued. This number is not increasing. So I think this shows that our sort of a lockdown and social distancing is working in UK.
What about you, Dr. Ghasibi? What do you think we should do for the public?
Yeah, I mean, it's difficult. It's a very difficult question, but I agree with Anna. You are doing a great job. In Italy, we started when we were we had 11,000. Now we have 180,000. And I mean, we started and we show people what was going on in northern Italy, and especially people of South, they were very afraid. And but I think that the real problem is that if you decide to have a strict lockdown, you need to take in account that you can have an economic crisis. I mean, because obviously people will not work. And I mean, you need to take in account that if you want to save life, you can. It will be hard to save your economy.
Exactly. There is a question, Mohannad Jarallah, he is asking if there is a pericardial effusion in COVID-19 patient, when echo should be repeated.
So I think it's like, in general, I would probably suggest that the management of this patient is just done the same way as if this patient did not have a COVID. And I didn't have a patient personally, but a colleague of mine had a patient with a sickle cell disease who came with pericardial effusion, and then required actually a pericardial synthesis, and then this was monitored because the effusion increased. So I would suggest that this is all being treated the same way as a patient who was COVID negative. However, then all the appropriate high full PPE is being followed.
Exactly. But Azam is asking, do you use the same PPE during all transesophageal procedures with a suspected COVID positive or low risk COVID, low risk included? Do you do that?
So thank you very much. That's a very good question. We generally feel that all the TOEs which we do them all in with full PPE, and that's the rule, because we decided we cancelled all our elective patients because we are not doing procedures, we are not doing elective surgeries at present. It's all being put on hold. It's only patients who are urgent, and therefore we don't have that many TOEs. And at every TOE, as I mentioned, we try to sort of select and make sure that actually the outcome of a TOE will definitely change the management or will guide the management. But answering your questions, we do use full PPE for all TOEs because this is a result generating procedure.
Yes, because actually the more strict, the more safer, you mean, with the procedure, even if he's a low risk COVID, suspected low risk COVID patient, the procedure itself is a very high risk, and no matter what, you have to do the PPEs properly. even if the clinical findings is not really highly suggestive of COVID. A question is, does ARB drugs can be effective to reduce COVID action on the lungs? It's a debatable question.
Sorry, what can I, because I
ARBs, the ARB drugs, angiotensin receptor blocker drugs can be effective to reduce the COVID-19 infection or not. I think this is a debatable question for ARB. Yes, a debatable question.
Yes.
Okay, as I'm asking again, is there any role of COVID screening for all patients prior to EE, considering high aerosol spread risk? It means that do you do a routine screening for COVID before you do 2E?
So no, we don't. We don't test the patient just because we are doing a TOE, but we actually behave like as the patient had a TOE, because of, I think this sort of answers the similar question to the previous one which I was answering. So the bottom line is we don't screen. We still ask patient whether they have symptoms, but as I gave the example of my patient did have ongoing fever, and he was COVID negative, but then based on other examples, the first sample of COVID negative doesn't mean they don't have COVID. So we sort of we use protection, and even though if they didn't have symptoms but there was a need for TOE, I would have used the full PPE.
Okay. Mohammed Journey is saying about the PPEs, most of the people just wear gloves and masks. Do you think it's enough to protect them?
So if it's for transthoracic echo, and this is for just as I showed on my slide, if this is a low risk patient, which means patient who these days patients who self-isolate themselves at home, even the families don't see them, but they drop them some shoppings, and so they really literally stay in a proper isolation if they don't have any symptoms, but then they come because they needs to be a certain decision which will guide further urgent management. Then we do use just the basic PPE, which is a gloves, apron, and just a surgical mask. So every PPE has got a mask in it, and then obviously if there is any possibility of risk, then we use a full PPE.
Okay, there's a question from Sophia and Maghrabi. Can COVID-19 cause endocarditis?
Well, I haven't come across a case report like this, and I haven't seen anything like this. So I've never come across anything. But we are all learning about COVID every day. There are new literature, new cases coming. So I haven't come across any.
Okay, Salim Habshi, in patient with positive or highly suspected COVID-19, any new role for other imaging, cardiac imaging modality, CT, MPI, MRI, to limited use of echo to reduce close contact? Both of us.
I mean, this is a difficult question because for echocardiography, I mean, you can use CMR. The problem is that it's not easy to sanitize MR. So,
yeah, because you use to, yeah. Go on,
yeah, to be honest, we prefer to use CT, and I mean, you can also perform tissue characterization with CT. So you can try to acquire a kind of late iodine enhancement to assess if there is any kind of scar. I mean, you have the same characteristic of gadolinium-based contrast agent also with iodine contrast agent. And at the same time, to be honest, we prefer to use CT because at the same time we can evaluate lung. We can evaluate, and when we administer contrast, we can evaluate pulmonary embolism, coronary artery disease, and at the end, we can also acquire a kind of LGE to evaluate the presence of scar. So if it's possible, yes, we need to avoid, we should try to avoid echocardiography or also invasive coronary angiography. But obviously, if you need, I mean, sometimes it's, I mean, it's mandatory. What do you think? What do you think?
Anna.
Yes, yeah. So I completely agree. Well, to be honest, I know that some of the centers who have more scanners, they do put like they do use one called COVID scanner, and the other one they call a clean scanner, because actually more we could offer to those patients is, for example, my patient who with the Takotsubo, I wanted to put her to the scanner, because then with those patients it would really help, because we would see a nice sort of in the stir imaging, we would see a swelling of the myocardium, we would see the myocardial edema, and this would really help us to differentiate immediately those patients. And so absolutely, if there is a capacity to do it, I would recommend it, but it's just the practicality of that. It's also, this is a current situation with COVID where we know it's so highly, it's all being spread, and we want to actually minimize everything. We don't want to expose patients. We don't want to expose actually staff as well. So we want to do things which are guide our immediate management. But actually, in the ideal world, I would love to have more imaging and actually understand those patients better.
Yeah.
Yes, exactly. Actually, what the latest recommendation from European Society of Cardiology, if the imaging modality is really necessary to change the patient management, then you go ahead and you do the MRI if you need for tissue characterization. It depends on the institute and the facility. For you, Gisibi, I know that they do robotic disinfection, which is very highly high tech.
But
so the robot is not MR compatible. That's why you can't get the MR.
Yeah, no, I mean, but we sanitize with just clean the machine, but it's always the same. I mean, also for CT, if you can avoid the CT, I mean, you don't expose, you minimize the exposure of personal health care.
Yes, and I think, yes, when is the modality CT MRI limit the contact, not like echo, and it is feasible, and the patient really need this for the diagnosis of myocarditis versus ST elevation MI, and you are really into going to give him a fibrinolysis or not, then this is justifiable because it's a vital answer for the patient management course. So it was, my point is negative. I think we had more questions coming in, and I don't know, Anna, do we have still time, Dr. Khalid? What do you think?
It's up to you, Dr. Yasmin.
Okay, I will take one more question if you allow me.
Yes, of course.
Okay.
Yes.
So I'm trying to pick a question that need an urgent when you are. Okay. When you're deciding to take nasal swab for high-risk patients, there is a special requirement to have this test. I mean, she means the PPE probably for nasal swab. She's asking if we take the nasal swab, shall we consider a special requirement to have this test as a personnel, which is the PPE, I think. This is the answer of your question. Then do you think, should we do, okay, the question, do you think we should do COVID PCR test for anyone going to the cath lab in the coming month and near future? Amit.
Well, I think it would be the ideal world. It's just the thing is that we all go through the phases and trying to expand the sort of the way to expand it to the staff, to the relatives, to the patients, and it's we have a really hardworking team who's working on it, and I'm sure in all the countries. So it's just a matter of the facilities. I think in ideal world, the other countries show that more we test, better we are in getting control over those the COVID. So absolutely, in ideal world, we should test everyone. But I think long term is probably this what will give us the better understanding would be if we manage to get the right test for the testing for antibodies.
Okay, the question is, what about lung VQ scan? Layla asking, Layla Khamis, what about lung VQ scan for pulmonary embolism?
How, I mean, you can do that, but I mean, it's at the end, I think that, I mean, at the end, I think that the best thing is to manage these patients when we have like species. As I told you, I think that my suggestion is to perform a whole CT with everything, with contrast and everything. If you have real suspicious that the patient had also pulmonary embolism and everything.
How to synthesize, one question, Bashira, she asked how to synthesize CT scan machine, disinfect the CT scan machine, she's asking you.
So for the CT scan, it's we had two steps. The first step, usually the technologists clean the machine, and after that we use like a small stuff that can sanitize all the environment, the air. But between one CT scan and the other one, between the two CT scan, we usually wait like for 25 or 30 minutes, because after that you sanitize the environment, you need to open the door, because obviously the liquid that you use to sanitize is toxic. So you need to wait a little bit, change the air, and I mean, it's extremely time consuming to have a dedicated CT only for COVID.
Okay, this is the last question we take, Dr. Shireen Barakat. As CT is more important in prognosis, what are the changes in CT in recovered patient? Thank you.
So for the changes in recovered patient, until now, it seems that there is no, that you have a normal lung at the end of disease, but we just checked a patient with mild symptoms. It will be extremely interesting to have a CT of patients that were in ICU. Probably they will develop fibrosis, but I think that we are still in an early phase of disease. So we will see the results after 1 year. And I think that in the next future, we will see what this patient had at the end.
Okay.
Yes.
This is another burning question, which is always the same. We heard many times the sample at the beginning was negative, then they found it positive. How this can be explained, and how long take to be sure about the results? We talked about it, I think. That's the timing of the sample might be not the right timing of the viral shedding, and the site of the sample actually, and maybe also the timing was not really when the virus is active, was in an incubation period. That's why we need to repeat. We need to take sample from not only the upper way, and also to have a time gap between the first and second sample taking. So I hope I answer all people question here. One thing, Dr. Gasibi, I want to take home message from you, and then Dr. Anna will ask you to do the same before we conclude our meeting. Dr. Gasibi, what is your take home?
So my take home message is to try to minimize the diagnostic examination, but in the same time, you don't have to be afraid to perform CT if your patient is worsening the clinical condition. Don't be afraid to administer contrast agent, and you have to think that all the examination need to have an impact, a very high impact in terms of prognosis of your patient.
Really valid message. What about you?
So what I wanted to say is that stay safe and use appropriate PPE, and be wary of COVID. But please don't forget about all those patients who are there in community, and make sure you also set up appropriate service and you encourage patients to come into hospitals, because we are really worried about those ones who are so scared of a COVID that their own condition continues deteriorating and we cannot help them. So I would also watch for these patients.
Actually, you're correct. In China, when at the beginning of the disease, when they are not using proper PPEs, healthcare workers get affected. But later on, when they use the proper PPE and rigorous PPEs, no one get affected actually by their own statistics. So if you are using your proper precaution, I think taking care of a patient suspected COVID or COVID positive is not a problem for the healthcare worker. Dr. Khaled, What do you think?
I think we had a great session today, and if you allow me, should we conclude?
Yes, please.
Okay. I would like to thank all our speakers, Dr. Anna and Dr. Gesibi, and your active moderation of the session. Dr. Yasmin, it was a great session today, and for all attendees, it was a great cardiac imaging session in COVID, and looking forward for all of you to have you more in near future.
Thank you very much. Thank you
Thank
for the
you.
attendees. You were
Thank
wonderful,
you.
all of you. Thank you very much. We're
Thank
going
you.
to end. Thank you.
Lovely. Thank you.
Bye-bye.
Thank you. Bye.